William F. Dockett. Mr. Dockett has been licensed and practicing in the counseling field for over 20 years. He has worked in Louisiana and in the state of Pennsylvania. He specialized in training in conflict management, women/gender issues, PTSD, dual diagnosis, and working with the adolescent population. He is also the author of a forthcoming book called Dual Diagnosis Issues. Mr. Williams Dockett.
Morning. Okay, let's see, where's the clicker? Oh. So as I was introduced, it was stated, oh, there we go. I've been doing this over 20 years. By a show of hands, how many folks are in that club? Okay. How many folks are longer? Okay. How many folks just started? Okay. So we have a couple of generations of practicing therapists, people in the medical or helping field, correct? Okay. So as the talk says, generational differences. So it's going to be a slightly different spin than the title may imply. But let me get through the disclosures. I work for Brentwood. That's about it. I'm also a MAT advocate. Okay, so as we go through this, a couple of things we're going to be touching on particularly. Figuring out bias. We all have bias. What do we do with it? We all have a culture. How does it impact us? How does it impact our clients? We all have a context. The context in which our people come to us, the context in which we operate. As also, we all have our perceptions. How does that play out? Okay. So as I was going through this, the data that's out there concerning opiate dependence, opiate fatalities, and just everything about it is just mind-numbing. As I'm sure you've seen from some of the other presenters, it's like we can talk data for days. But a couple of things kind of jumped out at me. I recently spoke at a stimulant seminar in Miami, and we had an individual from the Customs and Border Patrol office. And he was talking about the impact of fentanyl as a new generation of opiate or synthetic opiates impacting our clients and impacting everybody. Because one of the things he was saying is that there's fentanyl adulteration in almost everything, including stimulants. And if you see here, they had data up to fiscal year 19, which is currently 226 pounds of fentanyl. That's what they seized so far this year. Okay? Last year, they seized 388. Does that seem like a high or a low number? Especially when you start looking, cannabis, 46,000 pounds? Really? As well as heroin, 568. But how many of us in here realize that fentanyl is infinitely stronger than heroin? I could have less than a gram of fentanyl in here, and I could kill everybody in this room. So how many grams in a pound? Also, he made a point of saying that don't get stuck on the numbers. That is seizure rate. And he was saying that if they are lucky, they get maybe 10% of product coming into this country. That's a scary number. And given that fentanyl is here, and it's showing up in our regular opiate-using population of the illicit variety, and even sometimes of the pharmaceutical variety for people who order off of Canadian websites, Chinese websites, and the like, that's scary. Okay. So, one of the things, when I was looking at Louisiana, the best data that I could come up with was for 2017, saying that per 100 people, the average rate of prescriptions is 58.7, okay, per 100 people nationwide. How do you think we fit? Alabama, at the top. 107 prescriptions per 100 people. Arkansas, our neighbor, not much better. 105. Mississippi, our other neighbor, 92. We're 89. We are in the top 5. Okay, that is scary. The lowest is Washington, D.C. 28 prescriptions per 100 people. You know, what makes us so special? We're not along the I-95 corridor. If you notice, Florida's not on that list. Florida was notoriously known for the I-95 corridor of going from any and every place in Florida all the way up to Maine. We have I-10. Almost as bad. We have people working offshore, people who get hurt, a lot of accidents, a lot of injuries. So it's like, okay, yeah. But even still, we are well above national average. So, in terms of how do we stand locally, Rapides Parish statewide leads us at 213 prescriptions per 100 people. How many folks are there in Rapides Parish? I mean, not that many. I remember back in the 90s, Rapides Parish had one of the very first stimulant task force when they were trying to go after meth production. So I guess they've moved on in a way from stimulant production, because actually most stimulant production domestically has stopped. It's coming in from other places because they can make it cheaper, better, as well as with fentanyl. Bossier Parish, right across the river, 87 scripts per 100 people. Few more people. I think there's more people in Bossier Parish than there is in Rapides. We could argue that. Right here in Caddo Parish, 177 scripts per 100 people. Yes. 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 This came straight out of the, one of the things when I was doing the research, I came across the surveillance website. And the data that you can get from that is just insane. These are tracked through the state database. Now, Louisiana did something very progressive and very wonderful, maybe 8 years ago, possibly 10 years ago, and they created an online database for physicians, pharmacists, to track if any prescription is written in the state of Louisiana when it gets filled, where it gets filled, who wrote it, who filled it, blah, 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 blah. Where if your physician wants to, they can pull up your complete controlled substance history. Unfortunately, not many physicians have time to do that. That's the unfortunate reality. As the previous presenter mentioned, hey, when you come into my clinic, if you want me to write you a prescription, hey, I want a drug screen, I want you to go to treatment, at least see somebody. You have a couple of stipulations. Great. Unfortunately, that does not always fall true, especially on the physician side, because at best, our physicians get maybe 10 minutes per intervention per patient. That's not a lot of time. And also, as the previous speaker mentioned, he avoids the whole power struggle. When you ask somebody, hey, how many pills you taking? And you get somebody that does not want to be there, or how much you're drinking, or how much you're whatever. Nothing. You're not going to get that data. Also, once the physician asks that question, they are what? They're ethically and medically liable. Because once you have that information, you must do something with it. Again, just the fact of reality. So, here we have this chart. I have U.S. and Louisiana comparison of prescriptions going all the way back to 2006. We're beating the crap out of the country. I mean, it's on a downtrend, but that's still incredibly scary. So, in 2017, and again, this was the best data set I could find. 18 and 19 are still incomplete. Over 70,000 people nationwide have died from opiates. Legal, illegal, whatever. And that is, no, that's a very scary number. Locally, we're at 441. Louisiana has a population of 2 million people, if that. Nationwide, we're over 300 million. What's the percentage of that? Are we in a disproportionate status? Yeah. So here we go, the age adjusted. The average age nationwide is 21 years old for opiate deaths. Louisiana, it's 24.5. We're getting a slightly older population. All right, so enough with the data. I mean, because we could go on and on. But a lot of what we do is very qualitative. How many therapists do we have in here? Social workers, LPCs, LACs. Okay, great. So y'all are on the front lines. How many nurses do we have? Okay. Y'all are on the front lines, but also a little bit more secondary. Okay. And then, of course, physicians. 1, 2, 5, the wife, okay. So yeah, a lot of what we do is those soft, mushy things that are not very easily tracked. Yes, we can get the numbers, but a lot of what we do is very interpersonal. Hence, going back to where we started. Bias. Every one of us in this room has a bias. As one of the speaker beforehand mentioned, unfortunately, the medical field has had a very negative bias towards addiction, towards policing addiction, as well as using medically assisted treatments to adequately address it. Unfortunately, also, so has law enforcement. So have many of us as therapists or clinicians. How many of us have either been or worked with individuals that said, I don't want to work with no damn addicts. I just like my friendly neighborhood schizoaffectives. I don't do crackheads. Nah, that's okay. Bill can do that. This for some of us old enough to remember, that was the mantra for the vast number of our profession, especially in the 90s, in the early 2000s. Dual diagnosis? Please. What is that? It didn't exist. So we have our personal bias. Everybody has their personal preferences. You know, some people like coffee, some people like water. All depends on the situation. I touched on our professional bias. Our patients or our clients, of course, have bias. I only want to talk to a therapist who's been in recovery. Really? So if you have cancer, you only want to talk to a doctor that's... Yeah, really? Community. Our community as a whole has bias. We have legal bias. We have religious bias. We have all sorts, racial bias, ethnic bias, you name it. And because we are part of that community, all of that gets factored in. Does that make sense? Okay. I have a mantra that I live by. Not every therapist is for every client. It drives me when, oh, I'm a therapist, I can see everybody. Really? Yeah. And not every patient is for every therapist. How many of us have had somebody that we sat down and not even 5 minutes into an intake or a session, it's just, yeah, no, this ain't gonna work. How many of y'all honor that gut feeling? Sometimes, programmatically, you don't have a choice. You got to deal with it. Sometimes you can punt. By definition, going back to a lot of our Rogerian training, we are supposed to exhibit unconditional positive regard and be neutral. How many of us carry that off on a regular basis every single day? Some of us try. Again, very aspirational. Because bias is a part of our everyday life. How many of us have worked with peers in recovery that said, hey, I got sober this way. I don't know about this artsy-fartsy harm reduction BS, whatever that y'all coming up with, but the only way to get sober is abstinence only. Okay, great, that worked for them. How many of us have heard the term clean and crazy? Okay, clean and crazy refers to, hey, I'm going to get sober and I'm not going to take any meds. You don't need any meds. I'll go to my meeting, I'll talk to my sponsor. Meanwhile, your bipolar is all get out. You know, they've never heard of the concept of post-acute withdrawal syndrome. Okay. How many of us in here have heard of PAWS, post-acute withdrawal syndrome, and understand what that means? Okay, this is scary. Post-acute withdrawal syndrome is the withdrawal after the withdrawal. Okay? It'll have you looking depressed, it'll have you looking anxious because your brain is still being traumatized for up to 6 weeks after your last use. That's just the ongoing damage. The actual post-acute withdrawal syndrome can actually run for anywhere from 6 to 24 months, depending on substance used. Does that make sense? Okay. Am I saying something y'all have never heard before? Okay. Please, we need to educate ourselves. Again, I came in the 90s. I'm a product of SUNO, substance abuse treatment program, with Dr. Leave. They trained us. It was AA all the way. I happen to be one of those little weirdos that said, hey, not everybody can do AA. What about this thing called harm reduction? I almost didn't graduate. I'm serious. Simply because it did not fit his model of addiction treatment, his model of recovery. Now, did I have to say, okay, fine, let's do this? Okay, great. But, you know, we have to evolve. If we do not evolve, we get left behind. As our medical knowledge gets better, as our clinical training gets better, hopefully we evolve. And we're still not stuck with a lot of the stereotypes, a lot of the misinformation or bad information that several of us started off with. Okay? You know, back in the 90s and 80s, what came first when you were treating somebody for opiate dependence who happened to be schizophrenic or bipolar? You flipped a coin. Which one would insurance cover? Oh, we got to get them stable on their meds first. Meanwhile, they're craving and or using. Oh, we got to get them, okay, we're going to get them clean and sober. Meanwhile, they're manic as all get out. Were we doing our clients a disservice? Yeah. Did we realize that at the time? Yeah. Do we realize it now? Do we still have programs like that now? Unfortunately, we do. So, when we recognize our bias, it provides us with an opportunity for growth and evolution. Do you act on it? So, what I want you to do is, everybody, and I'm really glad they gave you all the programs with the paper in it. What I want you to do is, what are your biases on your clients? What are your biases on race? Your treatment approaches? Your gender or sexuality issues? Mental health issues? Addiction? Socioeconomic issues? Cultural? And last but not least, mat therapy. On the right side, I put, what do you want to do about it? Do you want to compensate? Do you want to educate yourself? Do you want to ignore it? Do you want to confront those biases or something else? Take a minute. What do you want to do with that? We're good? It's a short exercise. And it's homework for later. So, we're here at this conference. So, how many of you chose to educate yourself? That's an easy one, right? We're here educating ourselves about mat therapy. We're here educating ourselves about addiction. And our clients. Yay. Okay. How many folks chose to ignore a couple of things on that list? Let's be brave. Okay. Thank you. Okay. How do you compensate? Okay. Okay. Partially. She was saying by working through it, essentially. Okay. So, let's pick on race for a hot minute. How many of us in here feel as though because we happen to be African American, we can work with all black folks? How many of us in here feel because we're Caucasian, we can work with all white folks? Good answer. Everybody chuckles a little bit on an uncomfortable chuckle. But race is an overwhelming factor for just about everything that we do. Socioeconomic issues. Anybody heard the term, oh, you didn't hit bottom, you hit a high bottom. You only lost your job. Oh, man, oh, your wife only put you out. Oh, man, when I was out there, I overdosed 3 times, and they had to bring me back 4. So here we have a bias regarding what is a bottom. Okay? For some people, getting kicked out the house is devastating. Losing your job, devastating. Overdosing. Yeah, okay. So think about how you want to address these issues. Okay. So when a counselor denies that they carry a bias, they are doing a disservice to themselves and or to others. Okay. As we said, you need to evaluate the biases that you have. And again, for those of us that came in the 90s, early 2000s, was this ever a consideration? For those of us in here that came in maybe 2010 forward as part of your cultural competence or cultural awareness, was some of this touched on? Yeah. Cultural sensitivity was not a major part of my undergraduate substance abuse program training. Again, victim of the times. Okay. So, when you are faced with people's bias, you have to understand where they are coming from. Or at least try to. Okay. You don't have to accept it. You have to be aware of it. And to go back to compensating, that's more so, as I mentioned, hey, we treat everybody the same. We mitigate individual differences. Not a good thing. Context. Context is key. We have our setting and our role. That varies. Are we the counselor? Are we the parent? Are we Are we the individual in recovery? What are our patients' presenting situations? What is their context? As the previous presenter mentioned, a lot of times we don't get the full picture. We get either a snapshot, what they want to show us, or we'll get something from, oh, the person was arrested for blah, 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 or from a triage situation. Bless you. What is the impact of the events in the current reality? Why are they here? Context is dynamic in nature. It's fluid. We have to be aware of that. Our context is always changing. The context of this seminar has changed. We went from having a very medical approach, dealing with how to diagnose, switched over to more of a interpersonal therapeutic approach in terms of how do we handle things. And the speaker previously was much more of a data-driven approach. Has the context changed? Yeah. Okay. Perception. What's our view of reality? We're all sitting here in the convention center. For some people, it could be something else. What's our patient's view of reality? How many of us have told patients when they come to us with various goals, oh, be realistic? My mother used to tell me sometimes, I was like, oh, you approach everything with rose-tinted glasses. Really? Just because I have hope? Just because I want to look on the better side of some things, I have rose-tinted glasses. Got it. Love you, Mom. Perceptual differences. What's the difference between our view, their view, and possible other views? Any comic book geeks in here? DC, Marvel? Okay. All right. Well, the reason why I ask is because right now, they've been advertising the crap out of this. They're running, Conflict on Infinite Earth for people who are into DC. Batman, Superman, Flash, where the whole premise is there are infinite and multiple realities, okay? In one reality, you could be a therapist. On the other reality, you could be a banker. Everything else still applies, but your reality has changed. That's our patients. That's us. We have to be flexible. Okay. And I understand, it's something you might want to take a look at because it shows the possibility of and how sometimes things can be the same but very, very different, as also interrelated. You tweak one thing over here, kind of what they call the butterfly effect. You tweak one thing over here, expecting one outcome, but no, it screwed up something over here. Oh, we didn't expect that one, so you tweak that one again, it screwed up something over here. Meanwhile, you wanted to get here. How many of us have done that with a patient? Hey, you need to change your people, places, and things. You need to, hey, all right, we understand you're craving for opiates. We understand you've tried treatment 4 or 5 times. We're pushing for sobriety. We're pushing for abstinence. What do we fail to do? Did any of us talk about a harm reduction model? Did any of us say, hey, you might want to try Symposium or methadone? But again, depending on our context. Also, what is considered help? We hear this all the time at Brentwood. I didn't come here. I got forced here. So somebody just picked you up off the street and said, hi, Fred, you're going to Brentwood. Really? You had to be doing something. Something had to happen. A lot of times when people come into our programs, they're angry, as the previous speaker mentioned, and they're just not hearing it. You ain't helping me. Oh, I'm hurting. I'm detoxing. You ain't giving me nothing. I'm on 4 bags a day of heroin, IV, and, whatever else. You ain't giving me nothing. I'm still jonesing. Are we ignoring them? No. Are we giving them their drug of choice? No. Are we doing something to mitigate their discomfort and proceed with detox? Yeah. Either a benzodiazepine, in some cases, or a barbiturate. Okay. But it's not going to get them high. So they don't say, oh, you ain't helping me. You don't know what you're talking about. I'm going to sign at 72. Get me the hell out of here. Sorry, sir. You went through the ER and you were suicidal. You're on a 72-hour hold. Oh, by the way, you got to see the coroner. Culture. What is the impact of our culture? I touched on a little bit about this before. Are we aware that we have multiple cultures? How does one identity fit in? How do you identify yourself? And do you fit? What are the acceptable norms? So again, we're in the treatment culture. The old school culture is abstinence all the way. 12-step program, which works for some people. Absolutely. The acceptable norm is we are an abstinence-based program and we get all of our folks sober. God bless them. When somebody comes up and says, hey, how about Symposium, buprenorphine? We don't hear Orlam anymore. Does anybody know what Orlam was? Orlan was the transitional opiate agonist that the VA used to use between methadone and before buprenorphine came out. What are my professional implications? What's the culture of my profession? We're supposed to do no harm, right? Physicians take that oath. Nurses take that oath. I believe that's part of my ethical thing for my counseling license. Do no harm. But if we ignore treatment options, what are we doing? We're doing harm because it doesn't fit into what we agree with. How does it fit the culture of our agency? Good question. Now, I'm going to pick on CADA for a hot minute. CADA was here. CADA is a wonderful program. They are abstinence-based. The idea of mat therapy does not fit into their traditional culture. I hope they change. I hope they evolve. But, you know, that's just not part of their thing. You know, at Brentwood, we had a mat program for a short while. We tried it. And as the other presenter mentioned, a lot of times people were, hey, Medicaid will cover your prescription. You got to pay $200 to see your doc every month. When we did our program back in 2012, 2010, up until maybe 14, Medicaid didn't cover it. A lot of insurance companies didn't cover it. So what are we faced with? Hey, we get people stabilized. How many of y'all have had patients that come through our program, we get them stabilized on this newfangled medication, works like gangbusters, discharge them, and they find out they can't afford the medication? What did we just do? We set them up. You know, we see that a lot. We had to deal with that a lot. So, unfortunately, we no longer have that program because it was a 21-day program, get you in. We got you through the first couple of weeks of pause, got you stabilized. But again, it required a paradigm shift. We were a little bit too early. Is evolution change possible? Hopefully. If we don't evolve, if we don't adapt, we die. We become irrelevant. How many of us have an Android or an iPhone more particularly, from about 3-4 years ago? How does that compare to iPhone 11? How does that Android S4 compare to an S10? Night and day difference. What changed? Technology. Why don't we do the same? So, attitudes in addressing cultural issues. And this is important. We got the automatic, I'm going to do the natural right thing, the right and normal way. What does that mean? My way? Mama's way? The PC way? When I hear that term politically correct, it drives me. How about we just be correct? Screw political, just be correct. Acknowledge and accept people for who and where they are. Get with the program, or just keep your mouth shut and get out of the field. The taxonomy trap. Generalizations before become stereotypes. Damn addicts. They're all the same. Is that a generalization? What's the stereotype that implies? untrustworthy, can't do anything consistently, will manipulate the crap out of you. Are there some truisms in that? Yeah. But we've overly generalized it. The complexity trap. Screw it. It's too complicated. You have information paralysis. You hear this a lot with Matt. You hear this a lot with the LGBTQ plus population. You hear this a lot. Oh, it's too dang complicated. Just let them be. Just pick one. People are complicated. Life is complicated. Universality. I don't see color. Individual differences don't matter. Really? Going back to the other thing, do you treat all folks the same way? No. You can. How far is that going to get you? Not very far. How many people are you going to piss off in the process? A lot. Are they going to tell you that they're pissed off? Probably not. And then the separation. Nothing binds us, nothing ties us. We're all different. There's no unique commonality. So what's the point? That's kind of scary, isn't it? Do we know people like that who just believe, oh, there's nothing that ties us together? Yeah. Any of those people in the field? Yeah. Okay, so Prohaska and DiClemente. How many of us are familiar with stages of change? Hopefully, okay, that's disappointing. Stages of change is the mechanism by which we go about becoming aware and make decisions about life. In the context of therapy and treatment, it's okay, well, gee, I might have a drinking problem. Or I might be popping too many Lortabs. Maybe, but I'm prescribed them. So basically, it goes through pre-contemplation, which is pre-awareness that you have an issue. Saying that, oh, what problem? I don't have a problem, everything's good. The contemplation of, okay, well, hey, yeah, there might be some issues there. I might take a look at it, but I'm willing to talk to you about it, but that's about it. The determination. Okay, I'll go to treatment. I'm not going to do anything, but I'm going to go to treatment. Action. I will go to treatment. I need to make some changes. Maintenance. Hey, I'm in recovery. I'm on my meds. I'm doing what I'm supposed to do. How many of us deal with clients that everything's going really, really smooth, and all of a sudden they just stop taking their meds? Relapse. Oops, I did it again. Intentional, unintentional. And then back around. That's our clients. How does this fit for our agencies and for us? So let's use, we're here at an opiate conference. Pre-contemplation. I don't know anything about opiates. Opiates, yeah, doctors prescribe them. What problem? I don't see a problem with them. Outside, yeah, it's in the DSM. Got it. Yeah, okay. Heroin. Yeah, all right, yeah. Heroin, I got it. Fentanyl, maybe. Lortab? Now, please, that's prescribed. Okay, well, yeah, that might be more to this issue than I first thought. I'm not going to do anything about it, but I'm going to think about it. We're going to give lip service to it. Determination. Okay, bless you. We're going to have a meeting we're going to have a team meeting. We're going to reassess our clinic culture, and we are going to go forward and implement a MET program or opiate abatement program. We're talking about it. We actually do it at the action stage. And then once we get approval, and then we run the program. How often do programs that we just start that are new, conceptually, die at the relapse stage? How many programs have we seen that have tried to move from an abstinence-only model to more of a MAT model and their entire staff revolted? You have the revolt, the program doesn't work. You don't have the buy-in, the program doesn't work. Again, generationally. Okay, we need to get with the program. All right, so, as I mentioned before, I'm a MAT advocate, but when I did a presentation last year in Lafayette on conflict dynamics, this jumped out at me when I was doing research. How many of us have ever been in a situation, had done discharge planning, and you get everything, you get your client, everything's looking good, sounding good, they pass the interview, and then you send over the records. And then they say, oh, no, we can't take this person because they're on Seroquel. Oh, we can't take this person because they're on methadone, or whatever the case may be. Am I the only one? Okay. It's incredibly frustrating. When everything looks good, sounds good, then all of a sudden they slam the door in your face. Come to find out that's illegal. Medication-assisted therapy is covered under the ADA. There was a suit and a settlement about a year and a half ago, and the URL for the reference is there, which basically said for nursing home facilities and residential, they have to admit people on MAT therapy. Now, in the wonderful state of Louisiana in which we reside, I don't know how many of you have ever done discharge planning. Can anybody think of any residential facility that accepts Medicaid, or even that does not, where you can send a patient on Suboxone or methadone? There is none. However, it's part of the state plan. Again, evolving. The physicians have evolved. The technology has evolved. Hey, we have this newfangled thing which will help. Treatment programs, semi-evolved. Residential programs, no. Are we doing a disservice? Things to consider. But again, this is part of, and I have a slide up here, it's part of the state plan to address opiate dependence. So, in 2018, this is straight out of the Louisiana plan to mitigate opiate dependence. And it's available on the DHH site, and I've got the URL down there. Hopefully the slides will become available. In 2018, Louisiana did something really, really awesome. We got a Medicaid waiver so that we could provide MAT therapy and have it covered under Medicaid. Great. Going back to the stages of change. What do? We recognized we had a problem. We thought about it. We determined we're going to do something about it. We're going to have an action plan. We didn't hit maintenance. We went straight to relapse. So, and this is, again, this is straight out of the state plan. So, it's there. It's in writing. Where's the problem? Generationally. It's a generational issue. It's a treatment philosophy issue. Thank you.